So I am seeing only the 8 of us, which seems unusual. But let's toggle to our welcome slide. Next slide, please. Good, okay, people are starting to join, and hopefully we'll have Bob Kaplan with us shortly. If Kathy, if you would please contact Bob Kaplan to see if he's having any trouble. Or Hector, do you have his cell phone? I can do it, but here you are. He didn't receive the link. Okay, so here we go. Megan, please mute yourself, leave this slide up, and send Bob Kaplan the link. I recognize that cough. Hi, Dr. Balmer. I'm so glad you're with us.
Yeah, it took me a while to get in. So it just said, you know, meeting is not yet started. So it just let me in just now. So maybe others are having trouble too.
Well, I see that Bob Kaplan is having trouble as well. So I'm hoping that our team will figure out how to help him get into the meeting. There's sort of an infamous story about one of our very first summits, our second summit. He and our keynote speaker, Carol Mangione, who Hector Rodriguez used to work with at UCLA, got terrifically lost on the UC Berkeley campus. So we had to play it by ear a little bit. And that's what we're doing a little bit here. I see Dr. Yu has joined us and he has video, which is great.
Super. Well, you know, Zoom was down yesterday for several hours and was not usable globally. So hopefully, wow. Hopefully the servers are cooled down from yesterday and ready to run.
Well, I'm so glad that nobody told me that yesterday because I wouldn't have slept last night.
I almost emailed you that Zoom was down, but I thought, no, let's wait until the morning before we hit the alarm.
Well, it is just such a unusual time in the history of the world, and of course the RightCare initiative. We're so grateful that we've been able to successfully pivot to the virtual format, and we've put on 42 hours of programming this year so far with the help of our amazing volunteers, our faculty, our health system leader volunteers, and I see Bob Kaplan has joined, which makes me very, very happy. Hi, Dr. Kaplan. I saw you briefly there. There you are. Okay.
Yeah, unfortunately, I wasn't able to get, they didn't have the right link, so I'm sorry about that.
Well, we've been having a few technical difficulties today. Sorry about that. So I just want to say thank you to all of you for being with us. We have 92 people signed up for today. And we would not be here without the volunteer work of our faculty and our health system leaders that are here with us, as well as our sponsors who have helped coach how do you get the technology working through this kind of crisis pivot. I have to say in particular, Scott Flynn and Keith Emmons, a medical director for Blue Shield and a medical director for CenCal, which is the Medi-Cal plan in Santa Barbara, sort of taught me how to use Zoom, which was really, really important. And I'm so grateful for our team that includes operations team that includes a pre-med at UC Berkeley, our newest staff member, Jenny Wu, Megan Olson, who's been with us 3 years, Kathy Yarashevich, who just graduated from UC Berkeley. And so I want to emphasize to everyone that one of the key things that we do in RightCare is we're training future leaders. And I really appreciate all the training that the leaders on this call have shared with me over the years, especially Bob Kaplan. So let's go to the next slide, please. And I'm going to hand it over to Bob. So Bob, if you would unmute yourself, and thank you very much. So Bob Kaplan has a lot of credit to take in this project because he very quietly in 2009, after being on calls with us for over a year, he put in a grant to NHLBI to try to implement our RightCare triangle, which you'll see in a minute, in one place. And he had worked substantially in San Diego before he went to be the head of health services research at UCLA. And then once he got us started with our NHLBI grant, in which we received in 2009, by January of 2011, he pivoted and went out east to be the associate director of the NIH and left me and the team, who got to know each other really well, implementing our first regional group, to start the university best practices. In fact, he had gone by the time we had our first university best practices meeting, but came back to visit us during the summit. But one of the great things he did is he introduced me to Professor Hector Rodriguez, who was also part of that grant when he was at UCLA. Subsequently, we've brought him to Berkeley. So these are really long-term relationships that build, and I'm so grateful that people have stuck together. I think Jim Schultz joined our university best practices in San Diego in the early days, and he has implemented some really beautiful work that you'll hear about later. But right now I want to hand over the microphone to Bob Kaplan and say thank you for getting us started on our regional university best practices journey.
Well, thank you so much, Hattie. And it's really my pleasure this edu. I think many of you know Ed, but Ed is a graduate of the family medicine program at UCLA, and he's currently the chief quality officer at the Palo Alto Medical Foundation. There he's responsible for overseeing all the quality improvement efforts at PAMF. And he's just a genuinely really good guy who's very smart and really has a good sense of how medicine works and where it's going in the future. So Ed, it's a pleasure to have you.
Oh, thank you very much. Thank you for those kind words, Bob, and thank you, Hattie, for setting us up. And we are excited today of today's program. So Hattie, would you like me just to proceed with the introductions of our keynote speaker?
You know, Ed, I think it would be really interesting. Is one of the reasons we handed it to you so quickly is so that you could say a few words also about what you're experiencing at Palo Alto Medical Foundation between COVID-19 and the fires. The story you told on our leadership call the other day, I think others would be very interested to hear.
Oh, most definitely. I think the key word for I'm going to share with you is really about resilience. So just a little short story about where I am right now, where I'm with Palo Alto Medical Foundation in the heart of Silicon Valley. In fact, in Santa Clara County, the first case of COVID was diagnosed within our facility. So we were one of the first that had to figure out what to do, how do we keep our patients safe. And now, as everybody has known, everybody is doing the same model where we have respiratory clinics, launching them outdoors, and all the processes and checks to keep patients, staff, and physicians safe. Well, then comes along wildfires that was lit by lightning, and we didn't, again, unexpected. And one of the first challenges is that the air quality now has been so bad, and then most of our respiratory clinics are set up outdoors, and now we had to quickly pivot to adjust that to keep our patients safe. So one of the first things we had to do was to look in we serve in 4 different counties right now. And we also have, so a couple of respiratory clinics have moved indoors already, so they were relatively unaffected. But our Santa Cruz one and our Palo Alto one has remained outdoors. And we quickly decided that we had to close them down and then had to redirect patients to our indoor facilities. Fortunately, we are in the season where census for those clinics have gone down. So we fortunately have the capacity to accommodate them. However, another thing that we had to quickly do is to inform our clinicians team to be mindful of the decreased capacity for those clinics to see patients, and then kind of be mindful to help us in triaging those who need to be seen right away versus those that could be seen at perhaps at a later time, or are there alternative care settings, perhaps video visits that may be able to accommodate their needs in an appropriate fashion, and then find some other ways to do testing. So anyways, we're still in that process, and we're just lucky that this happened at a time where that we're in the lull of this. So we were able to capture that, and fortunately, we also have re-escalation plans that we did not have to activate yet, because we had already had plans about, in the event that we need a double capacity in our indoor clinics, where would the staff be? Do we have to space, and where will we shift in non-COVID care to other locations? So anyways, more curveballs may come and affect us. But anyway, I wanted to share that story to you all as a lesson about resilience and really about adaptability in these never-changing times. So thank you. You're on mute, Hattie.
Thank you for joining us. Many of you have sort of stepped away from your clinical work today to be part of this long-time best practices sharing format. And I'm not sure that you've ever met our wonderful ally at the California Department of Public Health, Catrina Taylor, the Chief of Cardiovascular Epidemiology. But if you would please put her bio up, that would be wonderful. Thank you for introducing the wonderful Catrina Taylor, Dr. Yu.
Oh, sure. Catrina, Dr. Taylor, really on behalf of the RightCare Initiative, we really welcome you to your presentation. I had a chance to preview your content, and I am myself really looking forward to it. But first of all, for our audience, you have her bio over there. Besides being one of the chief epidemiologists, she is the senior research scientist at the California Department of Public Health. Her interest and impact is wide. She's really interested in chronic disease prevention and mitigation efforts. And in particular, for these times, I really also appreciate the work she has led and has done in health disparities. That has been one of her focus areas. And in fact, she's going to talk about that in today's talk today, and also in light of COVID, which has highlighted the disparities that certain patient populations have faced. I think this is a very timely topic and subject for us to have. Another tying with wildfires right now, one of her research areas of interest is the impact of environmental irritants and exposure to our population with chronic diseases, and what are the efforts to mitigate them. So her work is very timely, has wide impact, and I'm just a joy to have her here. On a personal note, she enjoys a lot of outdoor activities. She, like me, also have 2 daughters. So I feel like there's a lot of connections and kinship here. But in any ways, don't want to take any more time, but Dr. Taylor, really welcome to the RightCare Initiative, and we look forward to your discovery and your lessons. So without further ado, let me turn the tables over to you, Dr. Taylor. Thank you.
Thank you for that. So I'll be providing, as Dr. Yu indicated, an overview about the burden of cardiovascular disease in California. Next slide, please. So in California, approximately 12 million Californians are affected by cardiovascular disease, which equates to approximately 1 in 3 adults. The 4 most common forms of cardiovascular disease that the State Department of Health focuses on is heart disease, heart failure, hypertension, and stroke. Next slide, please. This slide looks at the prevalence of the common forms of cardiovascular disease by race and ethnicity. The dotted line represents the state average for prevalence for each condition, and the percentages provided are those above the state average. So if you see under heart disease in 2018, the prevalence for California for heart disease was 6.8%. However, American Indians, Alaskan Natives, and whites were above the prevalence for heart disease. For heart failure, the prevalence was 2%. Native Hawaiians, Pacific Islanders, and American Indians, Alaskan Natives, and African Americans were above the state rate. Similarly, for hypertension, the rate was 29.8% in 2018, but the highest prevalence was among African Americans, followed by American Indians, Alaskan Natives, and whites. The prevalence of stroke was 2.1% in 2012 using the CHIS data, and the highest burden was among American Indians, Alaskan Natives, followed by African Americans. We do have 2018 data through our BRFIS data, which is the Behavioral Risk Factor Surveillance Survey. However, we have limited racial, ethnic components to that data set, but the prevalence of stroke is similar with that group. Next slide, please. On this slide, we see the prevalence of hypertension at a closer look. And what we look at is the trend over time. So from 2015 to 2018, what you see is that the prevalence of hypertension has remained relatively stable, but has gone up a little bit over time, with the outlier being in 2016. I also feel that in 2020, we're going to see another outlier with an asterisk, because we know that people's utility of healthcare services are going to vary during this time, whether it be due to delayed care or just the pandemic in itself. Those will have an impact on the prevalence of data for this particular year. But in this slide, what you'll see again at the dotted line is the state average, and those who are above that average have remained to be African Americans, American Indian, Alaskan Natives, and whites. It's important to note that in California, starting in 2014, African Americans began to experience the highest burden of hypertension, and again, with 2016 being the outlier. Next slide, please. On this slide, we look at the California leading causes of death for 2018. And among the top 10 leading causes of death are the 4 common forms of cardiovascular disease, to include heart disease, stroke, hypertension, heart failure, and then if you pay attention to number 7, it's other or unspecified cardiovascular diseases, which RightCare typically presents on a lot of these issues around acute myocardial infarction, cerebral vascular disease, and atrial fibrillation. But what you see is that the death rates are still high, and they are among the top 10, which makes cardiovascular disease the leading cause of death in California. Next slide, please. Although cardiovascular disease is a leading cause of death, California has done a good job in reducing the rate of coronary heart disease deaths. So Healthy People 2020 has an objective for heart disease and stroke to reduce coronary heart disease. And California was able to reach that. We reduced heart disease deaths from 97.4% to 87.4% per 100,000 people. Places like San Bernardino, Fresno, Merced, Tulare, and Shasta, while they did not reach that limit, what it shows is that while California is doing an awesome job, there are counties within California that are still burdened by cardiovascular disease deaths. Places such as Santa Clara, Sacramento, San Diego, and Los Angeles were among the counties that met the Healthy People 2020 Heart Disease and Stroke Objective 2 of reducing the rate of coronary heart disease deaths. They also did it at a rate that was greater than what the state did. So for instance, in Santa Clara County, you all have done an awesome job in the fact that you have been able to reduce the coronary heart disease rate by 45%. And in San Diego, it was reduced by 23%, whereas at the state average, it was only reduced by 10.3%. In other areas, we need to do more work. So for the objective for Healthy People 2020 Objective 3, which is the reduction of stroke-related deaths, we weren't able to meet that benchmark. However, we are still doing great work within our state. We just need to do a little bit more in this area. Next slide, please. In this slide, we look at the associated risk factors by race for cardiovascular disease. And we look at areas such as obesity and overweight, smoking, physical activity, no access to fresh fruits and vegetables in your neighborhood, because we always advise or recommend that patients with cardiovascular disease maintain a physically active environment, and that they do not smoke if they are smokers, and that they have a healthy diet. So when we look at this particular slide, what it shows is that there are racial ethnic groups that have a disproportionate burden of the associated risk factors. So for weight loss, the highest burden was among Native Hawaiian Pacific Islanders, followed by African Americans and Latinos. For smoking status, it was highest among American Indian, Alaskan Natives, followed by multiple races, Native Hawaiian Pacific Islanders, African Americans, and whites. For physical activity, it was highest among Native Hawaiian Pacific Islanders, followed by African Americans and individuals who report multiple races. When we look at no access to fruits and vegetables, fresh fruits and vegetables, it was highest among American Indian, Alaskan Natives, followed by African Americans and Asians. This is important to note because Asians have not been in the group with the highest prevalence of cardiovascular disease. However, if the burden or lack of access to healthy fruits and vegetables, they will become at risk, at greater risk. Next slide, please. So when we think about the cost of cardiovascular disease, it's continuously increasing. And in 2018, it was estimated that $51.9 billion were used to treat cardiovascular disease and were related to direct costs such as healthcare costs and indirect costs such as loss of productivity. Next slide, please. So when we look at health, and when we look at cardiovascular disease from a health equity lens, what we see is that the burden of self-reporting cardiovascular disease is highest among American, Indian, Alaskan Natives, African Americans, Native Hawaiian, Pacific Islanders, and whites. The burden of cardiovascular disease associated risk factors is highest among African American, Native American, Pacific Islanders, and multiple races. However, when we get down to who's dying the most from cardiovascular disease, it's highest among African Americans and Latinos. So we know that cost and access to care plays a huge factor in health outcomes from cardiovascular disease. So we really, as practitioners, have to ask ourselves, why are racial ethnic minorities or economically disadvantaged people of any background more susceptible of dying from cardiovascular disease? This is especially important because the rate of cardiovascular disease is projected to increase more than 10% by 2020. And when you think about the disproportionate share of racial ethnic groups who are reporting that they have cardiovascular disease, that rate is going to be exponentially higher for that particular group. Next slide, please. So we're looking at CVD or cardiovascular disease in the current environment or the current climate. And on this slide, I want you to really think about population share and how populations are impacted by cardiovascular disease, and or when a pandemic happens, how those populations are affected. So on this slide, you'll see a slash line which represents the population estimates for each individual racial ethnic group. To the left of that line, you'll see a blue bar and a red bar, which represents the COVID-19 number of cases and the COVID-19 deaths. To the right of that bar, you'll see the prevalence of various chronic conditions, such as hypertension, heart disease, diabetes, prediabetes, and obesity, because we wanted to include some of the associated risk factors that contribute to heart disease, and then also how health can be impacted by being diagnosed with COVID-19. So in particular, on this slide, the Latino population has a higher prevalence of COVID-19 cases compared to their population share. However, their number of COVID-19 deaths are not as high as their population share. They're almost similar in that population size. For Asian Americans, what you see is that the number of cases for COVID-19 is lower than their population share. However, the portion of deaths from COVID-19 are higher than their population share. This is also similar for African Americans. So when we're thinking about how populations are impacted and how their health outcomes can have a negative impact from COVID-19, we have to look at population share. Then when we look at the population share to cardiovascular disease and their associated risk factors, you see a huge burden, especially for Latino populations, for African Americans, and the American Indian or Alaskan Native population, and also for the Native Hawaiian and or Pacific Islanders. Next slide, please. So on this slide, we get a closer look through the equity lens. And what you see here again, where we see those striped lines, that is the population estimate. And what it gives you is a clear view of those proportions of the populations within the African American population and the Latino population and the Native Hawaiian Pacific Islander populations that are disproportionately burdened by either COVID-19 cases, deaths, or even the heart disease and heart disease associated risk factors. So as indicated in the previous slide, what you see is the higher cases among Latinos in their population for both COVID-19 cases and for deaths, and then for African Americans for their COVID-19 deaths. When you look on the side for heart disease and heart disease associated risk factors, you see again Latinos and Native Hawaiian or other Pacific Islanders who are being hugely impacted by heart disease in California. Next slide, please. So given the current environment, it's important to look at how other non-traditional factors are affecting cardiovascular disease among African Americans and Latinos. So in the current environment and its impact, it has an impact on care-seeking behaviors, other non-traditional factors such as health systems and their provider issues, and also whether or not they experience unfair treatment. Dr. Yu mentioned this in his talk. His group had to really look at and redefine their capacity when their capacity decreased and what that looked like for their indoor cases, especially when you have two environmental factors going on. You have COVID-19 and you have air quality issues. So in this instance, when you don't have that in place, here are some of the factors that may impact that. So when you look at cost, lack of care, or insurance, or other issues related to reasons for delayed medical care, you have Latino Americans primarily saying that those are issues impacting their access to care. For healthcare system or provider issues as barriers for delayed care, you have African Americans and Latinos who are saying that they're having these issues, whether it's for hypertension, heart disease, or heart failure. And for those who experience unfair treatment and how they feel like they're receiving care, it's primarily among African Americans. So when you think about what factors impact why and how people access or utilize care, especially during a pandemic, or when you have an added environmental risk factor, all of those factors impact the health outcomes of those populations. If it's delayed care, a person may have received a latent diagnosis. So at those points, it's very imperative for healthcare providers to really establish clinical criteria for potential risk, whether it's for diagnosed or undiagnosed individuals, and to establish a way to optimize their electronic health records so that they can enhance how they deliver their standard quality care. And then also to implement a plan for diagnosis of treatment of individuals with chronic conditions. Next slide, please. So on this slide, we also look at the ability to find a primary care provider, or how often you're able to get an appointment within 2 days in the past 12 months, or if you visit the emergency room in the past 12 months. During our current environment, doing the latter two are essentially, they find barriers. If there's no place for the person, and I won't say no, but limited space for a person to be seen in a primary care provider office, or they're afraid to go to the emergency room for care and they're having a cardiovascular event, that in essence is going to increase mortality rates. So when you look at difficulty in finding a primary care provider, especially around heart disease and heart failure, Latinos, African Americans are expressing that they're having a concern there. When you look at receiving or finding a doctor, unable to find a doctor within the 2 days in the past 12 months, you see African Americans and Latinos, or more so Latinos in this area. When you're looking at visiting the emergency room in the past 12 months, that's primarily African Americans. So if you take away the place of where they go to visit, or if there's barriers or there's a fear to go in to receive that care, that also impacts health outcomes. Next slide, please. So during this time, when we look at COVID-19, we really have to ask ourselves as epidemiologists and as care providers, why are racial ethnic groups or economically disadvantaged people of any background more susceptible of becoming infected or developing severe diseases and dying? And COVID-19 is really exposing and pressuring practitioners to answer these questions and how they decide to provide care. And also, what are possible underlying causes of differential outcomes of COVID-19 in populations burdened by cardiovascular disease? Next slide, please. So for us at the California Department of Public Health, what we were doing through our program, specifically Prevention Forward, we were awarded a 5-year grant from the Centers for Disease Control and Prevention to increase prevention and management of diabetes, prediabetes, hypertension, stroke, and high blood cholesterol. Next slide, please. And what we want to do is approach this through 3 objectives, which is to assess and increase the use of healthcare reporting systems to identify, report standard clinical quality measures, and refer patients with chronic conditions to nationally recognized lifestyle change programs. And through objective 2, identify policies and procedures within the healthcare organization to identify, manage, and prevent chronic conditions. And objective 3, assess the use of team-based models to manage, monitor, and refer patients with chronic conditions to nationally recognized lifestyle change programs. And our goal is to use a multi-level collaborative approach with health equity interwoven throughout activities to address these objectives. Next slide, please. So under objective 1, when we talk about using your healthcare reporting system, we're really trying to link our partner clinics, hospitals, and pharmacists to technical assistance to ensure that they're able to diagnose their patients, use their system to refer patients to lifestyle change programs within their communities, and to ensure that they receive standard clinical quality care. Not that one patient receives it, but all patients with hypertension receive it. Because then if everyone's receiving that standard clinical quality care, it ensures that when there are periods of delay or there's concerns from the patient's perspective on the care that they may or may not receive, they already know what they should expect. And by knowing what they expect, that impacts how they are able to self-manage their care when they don't have that access or where there's barriers to that access. And then also, Prevention Forward is promoting telehealth capacities to link patients to healthcare services to reduce delayed care. So again, I refer back to Dr. Yu, and I thank you so much for your high-level overview of what's going on in Santa Clara, because it really positions and opens up an environment and a space for telehealth. especially when you have limited space during COVID-19 and you have air quality issues for satellite clinics. So when you have to take these patients back to their primary location, they have an option to link up with a healthcare provider through telemedicine. And so kudos to Santa Clara for doing that. We're greatly appreciated for that. Next slide, please. Under Objective 2, we're looking at prevention for promoting the patient care process. And what that really includes is really including non-physician team members and how healthcare is managed. So looking at comprehensive medication management and medication therapy management to manage cardiovascular disease. And these times it's very essential to have non-physician team members such as the pharmacy, such as community health workers, and in some cases really going outside the box and potentially looking at, other areas. Maybe it's promotoras. It could be pharmacy techs who are providing some of the health education to the patients who cannot gain access to the healthcare system. So they still have to go and get their prescription drugs. I'm glad that various pharmacies are still open and have remained open and have given access to the patients so that they can receive their medication, but that creates an opportunity for a point for education. Prevention Forward is also promoting and hosting health education and self-management of cardiovascular disease webinars, where we really want to incentivize and motivate the practitioners to encourage their patients to self-manage, especially cardiovascular disease, because a lot of the outcomes are due to individual choices, whether it's around their physical activity, the meals they decide to eat, how they adhere to their medication. All those things are individual actions that can impact a person's health outcome, especially from cardiovascular disease. And then for Prevention Forward, it's also promoting adoption and implementation of team-based care approaches with inclusion of non-physician team members. Next slide, please. Under Objective 3, where Prevention Forward is really interested in sharing information about collaborative practice agreements and adoption. A lot of times, practitioners, whether it's the non-physician team members or if it is the physician, they're not exactly sure how to enter into those relationships to add non-physician team members to the care team. Well, the collaborative practice agreement is one route of doing that. And so we really like to share information around that to encourage and support those relationships. Prevention Forward is also working to increase equity capacity with community health workers and providers to promote improved awareness and treatment of patients with cardiovascular disease. We do understand that people have experiences with healthcare providers that are not always favorable to return for care. So in this instance, by having a person, an intermediary person to help with them navigating through the healthcare system, it helps, and it also links them to services that are available within their community. Prevention Forward staff also hosts webinars on lifestyle modification and referral topics areas regarding self-management of blood pressure monitoring and training. We have worked closely with the American Heart Association, the YMCA, and various other entities to really ensure that populations around California, especially the ones that we provide funding to, are able to link their populations to these services so that they can monitor their health, report that back to their physician, open that line of communication so that there is adaptability and cohesiveness between the patient and the care provider. Next slide, please. So overall, Prevention Forward, like on a quarterly basis and annually and biannually, we monitor treatment, management, referrals, and engagement in non-physician team members to reduce cardiovascular disease burden or negative health outcomes from being diagnosed with cardiovascular disease. And then also to prompt providers to come up with a plan to identify those who have not been diagnosed with hypertension, especially during a time when you have a new standard for what is hypertensive. So now we have a gray area for what is pre-hypertensive, really acknowledging those patients and getting them early to prevent them from becoming a patient with hypertension or other cardiovascular disease outcomes. So our next steps are to implement evidence-based interventions in Prevention Forward partner clinics, hospitals, and pharmacies, then monitor change in screening, treatment, and referring patients to lifestyle change programs and medication management programs. Prevention Forward is also monitoring change in communication between team members and use of collaborative practice agreements. We truly believe that our efforts in places such as Fresno, Monterey, Merced, and several other places like Los Angeles and in Sacramento, where the burden of cardiovascular disease is disproportionately shared, can be addressed by making this a collective approach, and especially having planning. And it's also important for practitioners to think about prevalence among their patient population. So really looking at what that looks like within your health system and what you're doing to reduce that. Next slide, please. Well, that is my last slide, and I'm not sure, Hattie, if you're wanting to open this up now for questions.
Definitely. We'd love to have our facilitators, Dr. Kaplan, Dr. Yu, start off with their questions, but I'm going to sneak one in first. Why do you think it is that so as you know, many of us have the shared family experience of losing loved ones early. In my instance, my mother did not know she had hypertension, and within a couple months of being diagnosed, she perished from a severe stroke very quickly when I was 15 years old. So when I heard you say, gee, we're making this great progress on heart attack deaths, which I've noticed in the data, I would love your thoughts on what are our next steps for really making better progress on stroke.
So that is an excellent question. I think a lot of it has to do with surveillance and with health systems reporting and identification. Early prevention and early diagnosis is always the key, because you have lifestyle choices as one component, but during this current environment, you have several other outliers that are impacting health outcomes. So it's very imperative, especially now, that younger people are having higher rates of obesity, having higher rates of fast food eating, lack of physical activity. They're all primed to become cardiovascular disease patients and to have early onset stroke. So a lot of it has to do with monitoring, early education, and a lot of prevention. So from a practitioner standpoint, they may see things that I don't because I'm on the data side. But from the data side, that's what it's telling us.
Dr. Kaplan, I'm not hearing you. You are unmuted. So would you care to share some thoughts on that disparity between cardiovascular heart attack and stroke from your perspective of health services research also?
Sure. By the way, before we do that, we do have opportunities for anybody in the audience to ask questions. To do that, just look at sort of the lower ribbon on your screen, and there's a Q&A box, and so you can just type questions in there. So on the stroke side, what I find interesting is that cardiovascular disease has been going down for a while now and hit some plateaus. Stroke seems to have been going down over the course of a very long time, maybe 80 to 100 years. And I was just curious about that. What do you think is going on with that?
Okay, so what do I think is going on with stroke levels going down?
Yeah.
Okay, so I do think a part of it has to do with patient care and access to care and how quickly people are understanding like stroke symptoms. So that's one component of it. I think a lot of it has to do with education. And then too, a lot of it has to do with lifestyle. So some portions of it is like some people are getting it. You have, like the data shows, people are taking their medication. They have been prescribed a plan. However, there's some disconnect between what the actual outcomes are, because clearly the death rates are happening. And they're disproportionate between each racial group. So, overall, I'm not 100% sure, but I think it has a lot to do with lifestyle and education and also care.
what do you think about the element of stress? Because I have to say my mother was in national security, and it was a pretty tense time in national security when she died.
So the key word now is toxic stress. And different racial groups are experiencing it at rates exponentially more than others. So when we talk about disparities in cardiovascular disease, there's also a disparity in the amount of stress. Current research is really showing that for African Americans in particular, when they go to the doctor, their stress is not even being acknowledged. And that's also true for women. And then men typically don't even express it. So it's you get the question of, how are you doing today? The first response is, oh, I'm okay, I'm fine. And then the person is maybe having a heart attack right at that moment. And then for others, it's, well, you know, your pain, it's a perception of a pain tolerance that people aren't either respecting or identifying. So really acknowledging that people are experiencing toxic stress, and especially whether it's in the workplace environment, if it's in your physical environment, if it's in your home environment, if it's continual, then the behavior of adhering to medication is going to have a counterintuitive effect, a counteractive effect. So if you are doing the right things and having a healthy diet, you are physically active, and you're eating right, you're taking your medication, but then you have this continual stress, your body has no opportunity to reduce that allostatic load. So your body is continuously pumping the blood hard to try to calm you down. And it's just not happening, which then leads to worse health outcomes, stroke early.
Dr. Taylor, so we have a question from Cheryl Hunter Marston, and she asks, she raises this issue. She said that she's seen decades of polypharmacy for hypertension rather than addressing social determinants of health and risk factors. So how do you dial back the needle and have providers address social determinants of health more aggressively rather than focusing on polypharmacy for hypertension?
Well, one thing is doctors have to communicate with their patients. In my previous work around asthma disparities, one component that we did, we really wanted to increase communication between the provider and the patient. So what we did was we created like little packet. Well, it wasn't a packet, but it was like a little sheet that they took in with them, because you know a lot of times you have the white coat experience and you'll forget what you need to ask the doctor. The provider is on a time limit, so the interaction is very limited. So really opening that dialogue so that you can get at some of the things to help that person. So if they are experiencing toxic stress, they feel safe enough to talk about it. If they are having some of the other health issues where the medication alone is not going to do it, really having a place where not necessarily you're venting, but you have a place to really talk about the patient's total health. Because we do know that health is not just about the physical body, it's also about the mental health. So if you aren't mentally able to take care of your physical health, then the outcome is not going to be the same, even when you address some of those social determinants of health, whether it's policy, whether it's access to care through insurance, whether it's access to medication. They're just not going to be able to do it because you have these other external factors that are impacting and impeding health self-care. So from the patient-provider perspective, you have to increase that communication.
Thank you.
So I don't know if it's more time. Oh, go ahead.
I think that Dr. Yu also wanted to weigh in on this.
Oh, I'm just so delighted that you brought it up, Dr. Taylor, about the toxic stress. What I wanted your input on is we asked the questions, how are you doing? And yes, as you mentioned, a lot of patients being polite, say they're doing fine when they're in fact are not. What do you think of the roles of we tried to do standardized surveys asking about anxiety and stress. How do you think that intervention would work? And then are there other insights from your research that you can guide us on how do we elicit what kind of wording should we use or what kind of methods should we use that makes it easier to unfold the toxic stress that patient has?
So for the first question, it needs to be an open-ended question. It cannot be a yes/no question. And I did learn that from my asthma disparities research. So if you ask the question, how are you doing today? They're going to automatically say, oh, I'm fine. It has to be more of a, Dr. Yu, you came in last month and you were telling us that, you went out running, you went out running. We know that the air quality has been bad. What have you done that's been different? To keep your physical activity going. That, number one, lets the patient know that, hey, you remembered something about me. This is kind of personal. Now you've created an atmosphere where the patient feels comfortable to share. So, you told me that you had some small children. How is that going? You have kids at home, during COVID-19 and the school year is getting ready to start back up. How are you and your wife or, you and your partner dealing with this? That opens up the dialogue for, we don't really know what we're going to do. We're not teachers. We're a little stressed out. We had to do it for a few months before school ended. We're not really sure. My kids aren't, it opens up that dialogue. It's like really putting your situation into perspective and annotating where there are opportunities to gather additional information. Survey questions don't always do that. It's sometimes about creating that personal relationship between the physician and the patient.
Excellent insight. Thank you.
You're welcome.
Dr. Hilo, I might have missed this in your presentation. So how did, in the analysis that you do, how do you define hypertension and diabetes?
Was that for me?
Yeah. So
oh, okay, sorry.
How does somebody get listed as having hypertension? And what definition of blood pressure do you use and assessment and so forth?
So really we use the ICD-10 code. So it would be, and I have to look them up right offhand, but we use the ICD-10 code. So it's typically around their blood pressure rating. And then for diabetes, you have to have at least have a hemoglobin A1C test, and then also had been told that you have diabetes.
I see.
But that's for our mortality data. For our CHIS data, it's all self-report.
Hi, this is Oliver Brooks. I'm just getting in. I'm sorry I missed some of your presentation. A comment, Dr. Yu had mentioned, how do you quantify it? How do you put the questions? I think that this is one of the reasons why African-American patients do better when they're treated by African-American physicians, because there's a diminution, I think, in the stress level just by walking in and having that there, A, and then B, there might be a cultural connection where you can read the person's face and know that they're stressed. So data does clearly show that African-American patients do better with African-American physicians, and that might be part of it. So the question I had for you was, did you address at all the fact that the toxic stress that is experienced can lead to the genetic changes in the DNA with the telomeres? I don't know if that was addressed. And it can be therefore communicated from generation to generation.
So that was not addressed in this presentation, but you are absolutely correct in the transfer of especially toxic stress on pregnant women. So for women in particular who are pregnant, there is a huge issue around stress management because that's immediately transferred during the pregnancy and post-pregnancy on the child and their health outcomes. And that's, again, especially important for African-American birth because we already have a low birth rate. And some of that has to do with some of the toxic stress. And especially when you think about education and you remove some of those social determinant barriers such as education and income, we are the women who are educated and or have higher incomes have some of the same birth weights as lower income, poor whites. And so when you take into consideration the stress on the parent to the child, it has a huge outcome in some of those health outcomes that they'll have later in life.
Thank you for addressing that now.
You're welcome.
Sounds to me like we need a whole presentation on that, Dr. Brooks. Maybe you can set us up for that. I've not heard of that in 12 years of running these collaborative meetings.
It's
You'll
somewhat
have to
new
help us find
information, but not that new in terms of the effect that you get methylated DNA and it damages more readily and it gets passed down. And it takes like 2 to 3 generations to get out of it. That's really the bad part. But I can pull something together on that, some of the studies.
Thank you. And I just want to announce to everybody that we're so lucky that yesterday, Dr. Brooks, who is the Chief Medical Officer of Watts Healthcare, joined our Los Angeles leadership team. So thank you. We really need your help. And Catrina, maybe you can help us also find the right speakers to further illuminate what you've been talking about today, because we would like to have more specific education on how to address the health disparities. Dr. Kaplan, when you were at the National Institutes of Health in charge of behavioral health, you probably came across quite a bit of information about this that you might want to share.
Well, first of all, the years I was at NIH, there was an awakening about social determinants of health. And I've got to say that the first couple of years I was there, it was acknowledged but not discussed much. And then interest has picked up. And if you look at the publications around the topic of social determinants of health and graph them by years, they kind of start trending up around 2008 or 2009, and over the last decade, they've really gone up almost exponentially. So it went from very little interest to quite a bit of interest. There was a book that we did at the sort of the end of my federal career that's on population health. And it's a free download, but it gets into a lot of these issues, including some of the issues that Dr. Brooks spoke about. So I think it's called Population Health, Behavioral and Social Science Perspectives. And it's, again, you can Google that and you can get it for free, or just look at the PDF copy online.
So Dr. Taylor, I so appreciate the leadership that you've brought to our Capital Region group and helping us with our data analysis and the partnership that we've had over the years. I know that you have little ones with you that you're taking care of this evening. So we certainly understand if you can't stay with us for the whole 2 hours, we'll understand. But I would love your guidance on connecting us with more programming and being more closely involved with us. I miss seeing your beautiful smile in our Capital Region meetings. So it's nice to see you by video.
Thank you. And thank you for having me.
And thank you for the presentation, Dr. Taylor. Great work, and thank you for your service to our patients and the citizens in the state of California.
So I think it's probably time now to pass the baton over to my friend and colleague, Hector Rodriguez. And I think he's going to introduce Dr. Schultz. Just wanted to mention that we have this new facility for questions and answers. And so while you're listening to the presentation by Dr. Schultz, you might be thinking about questions or even entering them in as we go.
Thanks, Bob. It's my pleasure to introduce Dr. Jim Schultz, who will present on not losing sight of hypertension hiding in plain sight while pivoting to COVID-19 pandemic emergency. And as you know, all are probably familiar with, the visit volumes in most outpatient offices has gone down considerably, patient volume. And as a result, many of the measures that we find so central to the RightCare initiative in terms of screening for hypertension and managing it are harder to manage because people aren't coming in for in-person visits. I think Dr. Taylor really underscored the disparities in our state with respect to hypertension management, and the organizations really grappling with these disparities front and center are community clinics, health centers, and public clinics in her state. And Dr. Schultz comes from a long history of seeing patients at neighborhood healthcare. He's currently the chief medical officer there since 2011, and is actually a part-time hospitalist at Palomar Medical Center. And in his leadership role as CMO, he's obviously been really central to growing health center operations, improving access to specialty care services, adopting new technologies, and achieving patient-centered medical home accreditation for his practices. He serves also as medical director for Project Access San Diego. He has his medical degree from UCLA and his MBA from CSU San Marcos. He also, interestingly, you can ask him about this in more detail as it relates to the presentation, but he's also a candidate for an international diploma in mountain medicine and working toward a fellowship in the Wilderness Medical Society. He's been a longtime advocate and proponent and collaborator of the RightCare initiative, first joining in 2011. This presentation really cuts across a lot of the payment reform and delivery system change that needs to happen in community clinics and health centers to better manage hypertension, especially during a time like right now. So some of the things that you'll hear from Dr. Schultz today is really how to scale solutions to hypertension management, how to leverage payment models to overcome, previous incentives that have limited our ability to use team-based approaches, using registries for comparative analytics, really thinking about workflow redesign and team huddling and population management approaches to make sure that patients, not only the ones that are presenting in the office, but those that are out in the community and not necessarily receiving care, are managed, and also innovative use of retinopathy screening through telemedicine for managing diabetes. And so I think you'll see in this presentation a lot of Dr. Taylor's visions around providing team-based care and sort of the infrastructure needed to improve hypertension management actually happening within neighborhood healthcare. And so Dr. Schultz, I'm very pleased to introduce you, and I look forward to hearing about your journey and to the questions from the audience about your journey. Thank you.
All right, thanks very much. We can go ahead and start the slide set. So this is a temple in Pimai, rural Thailand, Isan, and this has a sort of tangential significance to what I'm going to talk about today as it relates to COVID, because this is where I was when COVID broke out in China, and then the next country was Thailand while I was riding a bike across Thailand. So I'll talk about that a little bit. Next slide, please. So this is my goal slide for this talk. So I'm just going to talk about what my clinic has done for hypertension control over the years, and how we've tried to stop the leakage during COVID in hypertension control. I'm going to talk a little bit about undiagnosed hypertension, because it can be a big problem that's not well recognized in really any clinical setting. And then how in your organization you might be able to determine if you have an undiagnosed hypertension problem, and how you take care of that problem. Next slide. We're gonna have a little quiz. This isn't a poll, so you can just answer it in your own head. So how many people in the US have undiagnosed hypertension? 2 million, 5.4 million, 12 million, or way more now than before March? There might be two answers to this question. Next slide, please. How do I know if I have hypertension patients hiding in plain sight in my office or my healthcare system? A, use the CDC Million Hearts Hypertension Prevalence Estimator. B, use my registry to run a report. C, both A and B, or I don't have any of these patients. I'll give you a hint. The answer is not D. Next slide. What's the most common reason for hypertension going untreated in our active patients? Lack of insurance coverage. I'm a community health center, so that might be my answer. not going to the doctor, no primary care physician, clinical neglect, or inefficient clinical systems. And we have evidence-based answers coming up for all of these questions. Next slide. What's the best way to rapidly improve your group's HEDIS hypertension control rate? A, improve blood pressure measuring technique. B, reduce clinical inertia by the use of treatment guidelines or protocols. C, entering the home blood pressure readings into the blood pressure field in your EMR. D, all of the above, or A and B. And this answer has actually changed in the last few months. Next slide. How can you reduce mortality and morbidity related to undiagnosed hypertension? Pre-visit planning and proactive office encounters, promiscuous use of a registry, point of care real-time reporting, prayer, or all of the above. Okay, next slide. Now that you have your answers cemented in your head. So a little bit about neighborhood health care. These are our fairly current statistics. We're in the border county of San Diego, which means we have a lot more COVID here than most of the counties, especially in the southern part of our county that sits right on the border. My clinic has 16 sites in 2 counties, San Diego and Riverside County, Southwest Riverside County. We have about 74,000 patients, and we did about 300-something thousand visits last year. We have a pretty robust behavioral health department, including integrated behavioral health into all of our primary care sites. So we had about 24,000 behavioral health visits. We see kids, old people, and everybody in between. We do prenatal care. Our budgets, I think our budget's hitting closer to 100 million this year. We have about 58 full-time medical providers, and we have almost 0 full-time medical providers, but so they're all working like 60, 80, 90%, but 58 FTEs, 7.5 FTE dentists at 3 sites. We have 3 PharmDs and 26 FTE behavioral health providers. And we have we've contracted with some outside offices to provide medical and dental care to our patients. And as with any community health center, we're a nonprofit. Our board of directors consists of more than half of whom are our patients. Next slide. And this is what we do. We do primary care, prenatal care. We do a lot of psych care, including some serious mental illness. We do addiction therapy with medication, MAT. We have pharmacist-led medication therapy management programs. We do retinopathy screening and get our images read up at Berkeley, actually, by IPACs. We have dental, podiatry, acupuncture, and chiropractic in-house in most of our primary care sites. We've had a long history of intensive diabetes, RN CDE-led diabetes management program. And we've started that at one site, at the main site where I'm at right now in Escondido, and have spread that out to our other large sites and feed patients into that. We did have an extended hours, and we did have a retail clinic. So all the stuff in red has sort of been curtailed with COVID, unfortunately. We're starting to open up some of these things again now. And then we have a medical clinic that we embedded in a homeless center and soup kitchen in Escondido too. That's one of our newer primary care clinics. Next slide. Monthly visits, we do about 1,400 or 1,500 visits a day prior to COVID, and right now we're averaging about 1,300 visits a day, even without, and those are all pretty much all medical and behavioral health at this point, because our chiropractic is limited, podiatry is limited to emergencies, dental is still fairly limited. We're opening that back up again a bit. And acupuncture we have not started again yet. So we've almost made up for all of our visits by doing telemedicine stuff. You can see the breakdown between primary care, psych, dental, walk-ins. We do about 5,000 walk-ins a month. And our payer breakdowns, mostly Medi-Cal, a lot of still unfunded and uninsured, being a border county. Next slide. And this ties into this our payment model. If for those of you that aren't in a community health center or aren't familiar with it, we're basically have a very convoluted rate setting process that gets into both federal and state areas, audits, and formulas. But basically it boils down to we're paid per visit for certain types of visits, and we're paid nothing for other types of visits. So if it's a physician or PA, MP, a PhD, a dentist, a chiropractor, acupuncture with limited number of visits, optometrist, we get paid per visit. And it doesn't matter if we're seeing somebody with an upper respiratory infection, or we decide we want to do open heart surgery in the office on an outpatient basis, we would get paid the same for those 2 visits. So it's X dollars per visit, and each site has their own rate. So all of our 16 sites we have 16 different rates. We have to submit a scope of services document to the federal government every year that says what we do, and we're not reimbursed for anything outside of that scope. We have to build our buildings according to OSHPD 3, which is basically like a hospital, so it gets very expensive. We have to see anybody that comes in without regards to their ability to pay. And we don't get reimbursed for pharmacist visits, nursing visits, health coaches, PT, OT, speech therapy, respiratory therapy, patient navigator, outreach workers, and all of that kind of stuff. Next slide. So here's how we're doing for hypertension control. And I've got 2 SNPs. This is taken directly the other day from one of our live reports. So the top number is a 3-year trend, and you can see our 3-year average is around 78%. Ignore the colored line, just kind of look at the numbers. We peaked at 80%, and you can see that like the black line is leaking down a little bit toward the right-hand side, which is today. And so I changed the filter to an 8-month average, and you'd see our overall rate for the 8 months is 75%. And if I take a snapshot of what it is, I look today at 72%. We have about 12,000 patients diagnosed with hypertension. So we've actually probably dropped from 79 or 80% at the beginning of the year to 72% today. So that's not great, and we're not happy about it. Next slide. And so if you take a subset of patients with diabetes, our hypertension control rates have generally been better in our diabetics, I think just because maybe we pay more attention to them. They're getting more other services, so we have more opportunities to intervene on their blood pressures. And I think just clinically, we probably care a little bit more about the hypertension in the diabetic patients than we do if they don't have diabetes. And we're using 140/90 as our cutoff still for both diabetes and just straight hypertension patients. So you can see we peaked, and we kind of been hanging out at 80% for 3 years. Right now we're at 75% today, and that's for about 6,400 diabetics. Next slide. So that's leaking too, as you can see. We try to track disparities. We don't collect good data on race and ethnicity. We try, but our patients leave that blank or don't fill it out, or they can't really explain in one checkbox what they are sometimes. So we have used to look at disparities in the past. We've been mostly concerned about since we do so much behavioral health, do our patients with serious mental illness get the same medical treatment as the rest of our patients? So that center box is SMI patients, and if they don't have SMI, their blood pressure control is 80%, and if they do have SMI, it's 79%. So that seems to be pretty close. Our big disparity is if they have insurance or not, and we've got a 5% gap in blood pressure control on our uninsured versus our insured. And then we've kind of always used the primary language, which we identify much more, or the patients fill out much more commonly than they do race and ethnicity questions. So we look at primary language as a sort of surrogate for race and ethnicity disparities, and we haven't really been able to identify, based on primary language, a huge disparity in blood pressure control. Our two biggest groups here are Spanish and English. We have a very low African-American population at our clinic just because of where our clinics are located. Next slide. So how do we get the control that we get? I think the keys for us, and I'll talk about some of these, are we have live, accurate data at the point of care for the people that need it, for the doctors, the nurses, and the pharmacists. We've always had a pretty high emphasis on quality at neighborhood healthcare from the leadership on down. Our current CEO is a family physician who I hired, and so he's kind of come up in the organization as in the milieu of paying attention and emphasizing quality, and our board has actually set diabetes control and cancer screening, and part of diabetes control is hypertension, as the 4 metrics that we're supposed to pay the most attention to this particular year, and also factored into his bonus, our CEO's bonus. I think we've been pretty active on patient engagement, and I'll talk about that. Most of our MA staff, medical assistant staff, has gone through motivational interviewing training, as well as the RNs. And there's part of their onboarding now. We rely on our non-physician staff a lot. And also we've really incorporated social determinants of health and behavioral health into our primary care practices. We have behavioral health in all of our primary care sites, even our small ones. And that may be a counselor, it may be 2 counselors, it may be a PhD psychologist, it may be a double-boarded family medicine psychiatrist. And then we started screening for social determinants of health maybe about a year ago, and we've successfully screened almost 80% of our patients for social determinant factors, and we have an action plan based on the severity of their social determinants screening. Next slide. I think the thing that has helped me and other physicians the most is we have, our EMRs are not that helpful, to tell you the truth. In fact, we have eClinicalWorks, which on the physician side is probably better than some, but in general, they just suck. They just kind of get in the way most of the time, and they suck up all of our time. So we have scribes that deal with like the documentation issues. So what we did is we have a physician who in a previous life was a SQL database programmer, and we put him to work. And so he and our data team have designed this thing that the big red arrow is pointing at. We call it our ECW, eClinicalWorks Alerts app. And you can see this is a screenshot of a test patient, but this is what eClinicalWorks progress note screen looks like. And the right panel has the problem list and the med list and all of that. That little right-hand corner is a pop-up that runs in front of eClinicalWorks, and it's set up to open automatically. So when we open our EMR, that also that utility opens up as well. This is our thing. It's not an eClinicalWorks thing. Next slide. So this is what the Alerts app looks like, and we keep adding more and more stuff to it. So now it has an up and down scroll bar. But this has, you can see this is my test patient. And we added in March, we added a COVID risk calculator that just pulls data. Basically, it sniffs data from our database and answers all the questions that are being asked on the left-hand side of that Alerts app. So we added COVID risk in March. We have ASCVD risk calculator that calculates the risk. It's not showing up in this one because there must be some data missing, like maybe she doesn't have real lipids, I think. So it shows when her last blood pressure was and what it was. And that's set up to turn red if there's anything not meeting our goals, or if it's like if A1C hasn't been done in 6 months, it'll show up red. And it's patient specific, so it won't show pap smears in a male. And it won't show colorectal cancer screening in somebody less than 50. It won't show AAA screening in inappropriate population. So, and so usually these alerts are mostly black. And if there's something, so the red really stands out. So it's real-time data and it's actionable. So if the A1C there says none, I can click on the A1C and it orders an A1C. I don't have to go back into the EMR, go to the lab, tie a diagnosis to it. I can just click that, or I can ask my MA or my scribes, order A1C, and they can do it for me. It's verifiable, so most of these are hyperlinked. I have a hard time believing the calculated ASCVD risk on a lot of my patients, just because when I look at them, I don't think they're that high, or I might think it's really high, and it's not, and I don't believe the calculation that I'm getting on the Alerts app. I can click on it, and it takes me to the website and fills in all the formula and proves to me that my gestalt was wrong and the calculator is actually right yet again. And then when you hit one of these, it also satisfies our quality reporting metrics too, if it's been ordered and done. Next slide. And this is also role-based. So my Alerts app screen is set up for me as a doctor, and my medical assistant's Alerts app is a little bit different, and the PSR front desk people have a little different app too. We have a lot of reports. This for example is one screenshot of, as you can see, it's the middle of a scroll. So we have many custom reports we've set up, because of the ones that come built in the eClinicalWorks are either not good, or they're just not set up quite right of how we want to use them. So we spend a lot of time building our data. We own our data, and we made eClinicalWorks give us our data, or give us access to our data, and we use it a lot. So you can see here what I circled was we do have a undiagnosed hypertension report that we run pretty regularly. Next slide. And then we report out on quality, and so part of that eClinicalWorks, the Alerts app that we run, is anybody using it, any provider, any administrator, front desk person, the janitor, if they don't really have a good reason to be in the EMR, so they better not be in there, but anybody that can get access to, we make all of our data transparent, so anybody can get access to the data in about 2 clicks. So this is a summary quality dashboard that we have for the medical staff, that we can all see where we rank each other. And this was taken August 21st, so this was Friday. And one of the 5 measures that we use to rank our medical staff against each other is hypertension. So this is kind of, it's a point of emphasis at neighborhood health care. And you can see it's a Z-score, so it's graded on a curve. There's a bell curve, and the Z-score, just like in your any other bell curve or in your bone density reporting, is how many standard deviations you are above or below the mean. In this case, the mean is all of the medical staff at neighborhood health care. And we move up and down on this list quickly and frequently, because it just varies by where you are with your disease management and quality metrics on that given day. You kind of see that this is the top, I think maybe the blow up is the top, 8 or 9 people. And our blood pressure control in that group of people is pretty high. Next slide. But even down in the middle folks are running 77, 72, 69% on blood pressure control. Next slide, please. So I'm going to talk about undiagnosed hypertension a little bit. Next slide. So this comes from an article published in JAMA in 2014 by Hilary Wall and Janet Wright and Judy Hannon. And it explored how we might be missing a lot of our hypertension patients. I mean, it really gets back to Dr. Taylor's presentation too. I think some of our mortality, morbidity, I think is due to this group of folks who are running around with hypertension and don't know it, or they know it and they're not doing anything about it, or we're not doing anything about it. Next slide. So there's some of the stats for just general hypertension prevalence in the US. And at the time of this study, they were estimating about 40% of hypertension patients may not be diagnosed. And we have about 70 million hypertension patients in the US. Next slide. And we all know, like, the impact of hypertension, if you don't have hypertension, you live 5 years longer. If you reduce blood pressure by 5 millimeters, it's not even to goal, but if you just reduce it by 5 millimeters, you have some pretty significant impact on stroke and ischemic heart disease. And also, even without regards to if you get any reduction in blood pressure or not, if you're on an antihypertensive medication, you have a reduction in heart attack, stroke, and CHF risk, especially CHF. Next slide. We all want to treat to goal, but sometimes just like identifying the problem and getting the treatment started is most of the battle. So if this is the breakdown of people with uncontrolled hypertension, about 16 million are aware and treated, but they're just not controlled yet. About 6 million are aware, they know they have hypertension, but they're not being treated. And then about 14 million are unaware. And that actually adds up to like 36 million, not 34 million. Sorry about the math. Next slide. So why? This article by Hilary Wall tried to explore what are the excuses, what are the reasons, why do we have undiagnosed hypertension? Is it because people don't have insurance? Well, of the people that were undiagnosed but had it, 82% had insurance. Is it because they don't engage the healthcare system? They don't have a primary care physician. 82% had a usual source of care. Is it because they don't go to the doctor? Well, 62% had 2 or more visits in the past year. So those aren't necessarily all of the reasons. Next slide. So the recommendations from the article was look at your practice data, develop some sort of systematic approach to identify potentially undiagnosed hypertension, and try to figure out, like, what Million Hearts folks did is they came up with a hypertension prevalence estimator that you can apply to your practice. So you can look at use their estimator and see if there's a big disparity between what you're showing to be the prevalence in your practice and what the predicted prevalence would be. Next slide. So here's typically when we figure out what our group's hypertension prevalence is, we put in the denominator all the patients who had been diagnosed with hypertension, and then for the control rate, we put in how many of those patients have both the systolic pressure less than 140 and a diastolic pressure less than 90. And the HEDIS definition typically is the last blood pressure recorded in the chart, but you can't use a home blood pressure reading. Well, right now you can, but typically you've not been able to use a home or ambulatory blood pressure reading. But this can be a little bit of a problem. Go to the next slide. So if you think you have 1,000 patients with hypertension based on your problem list or your assessments, and you have 750 of them with a systolic under 140 and a diastolic under 90, that's 75% control rate. It's not bad. But what if you also have 500 undiagnosed patients? Your denominator goes to 1,500 and your actual control rate now is 50%. So that's not as good. Next slide. So this the hiding in plain sight article looked at two groups, Geisinger and Palo Alto, Dr. Yu, back in the day. I think it was in the, probably in paper chart days. Geisinger found their prevalence rate, they were missing a lot of the hypertension patients, and their actual prevalence they thought was 18%, and it was actually 26%. Because they were missing so many folks. Next slide. And this is Palo Alto Medical Foundation from the HIPS study showed that 37% of their patients who had more than 2 hypertension readings did not have ICD-9 at the time, ICD-9 code entered into the chart for hypertension, and so their actual prevalence was much higher than what they were showing as well. Next slide. So again, the CDC recommended this sort of process for how you deal with the undiagnosed hypertension population. First of all, you have to decide what your clinical criteria for hypertension is. You should set some sort of alerting process for potential undiagnosed hypertension patients. Do some sort of search using a registry, and then you come up with a plan of what you're going to do with these patients once you identify them. Next slide. So there's, you can get a hint about this using this hypertension prevalence estimator. Next slide. And it's right on the Million Hearts website. There's called a hypertension prevalence estimator tool, and there's a hyperlink there. Next slide. And their estimator tool is pretty elegant, and if you have these data, you can enter socioeconomic status of your patient population, those comorbidities, diabetes, obesity, and chronic kidney disease, age, and race and ethnicity. So if you have that information, you can enter that to really fine-tune your prevalence estimator tool. So we did that. Next slide. So this is our actual data table from the data we entered in the hypertension prevalence estimator, and we came out with our overall prevalence should have been 27.5%. Next slide. Or our overall prevalence was 27.5%. Our estimator was supposed to be around 23%. So we actually had more, our data was showing that we had more hypertensive patients than what the Million Hearts hypertension prevalence estimator, based on the data that we entered, estimated we would have had. So we didn't think, when we first did this, we didn't think we were, based on this, that we were missing a bunch of people, but then we went to try to find out if we were or not. So next slide. Oh, sorry, next slide. So we went into our registry and set up the query, and basically we asked, we were asked to look for patients that did not have the diagnosis of hypertension, either in an assessment anywhere or in their problem list, and they had more than one office visit, because we have a lot of, walk-in acute, that 5,000 walk-ins a day, a good half of those we only see the one time, we never see them again. So we wanted them to be actually our patients, and that they had more than one systolic pressure 140 or higher, or more than one diastolic pressure 90 or higher, or they were on an antihypertensive medication. Next slide. And the reason we added that last one is if in case we had patients that transferred here from other places being treated for hypertension, but we didn't enter that diagnosis anywhere. We also started into a study that was a combined National Association of Community Health Centers and CDC project, and with some other clinics, and that we were in there with 10 clinics in a study over a 12-month period, and the group of us we found we had to average about 7% of undiagnosed hypertension patients. I think we were number 4 in this one. We were in the 2.5% range on this one. Next slide. So the first thing we did was like get these folks into the office. So, and this was either, sometimes we don't have great access all the time to the physicians because we're busy all the time. So we set them up, if they're an established patient already, with either an MD visit or with a nursing visit, and we had some protocols set up for the nurses to do blood pressure checks. We set up some appointment slots for MA only blood pressure checks, where they basically just come in, get their blood pressure checked by an MA, recorded in the chart, and leave. And then we also have some population health staff, including some health coaches that can do the blood pressure and do some health coaching at the same time. And then in addition to that, we set up some we call them flip visits. So they're seeing the MA, the blood pressure's high, it looks, there probably should be some intervention done. Come grab the primary care physician or anybody else with a license to practice medicine in some form or another, and get them to do a quick visit face-to-face with the patient and make an intervention or a change. One of the things we found that we weren't doing a great job of consistently recording blood pressures, and since we're always kind of rush, get the patient in and out, we're sort of doing rapid blood, you run the patient back, get them in, give them 10 questionnaires and screening forms, SDOH things, which raises their blood pressure a lot of times. We're trying to do trauma-informed care. We're doing ACEs screening now, and then we take their blood pressure. So all while they're like trying to fill out the forms and stuff. So we really tried to refine our blood pressure measurement protocol. And patients sit down, both feet on the floor, don't let them talk during the blood pressure reading. And then the other thing we did is if the first blood pressure reading is high, we repeat the blood pressure at some point during the visit. So typically, if I'm not going to the room right away and there's time, that the MA will do a second blood pressure reading. And pretty much automatically they do a second blood pressure reading if the first one is high. If it's still high, then we will frequently have the MA come back and take another blood pressure at the end of the visit, if I didn't make the patient mad for some reason. So then we try to take kind of what we've said is that we're going to enter the blood pressure that gets entered into the structured data field is the one we're going to take clinical action on. So it might be the highest one, but in most cases it would be the last one of the visit. And then if it's still high, then that's what stays in there. Next slide. I think the key thing was getting these folks into the office. And we can just skip this slide. What we found is we were able to get about 70% of our patients eventually, you can see it took almost a year, into the office of the undiagnosed hypertension patients. So it can be done. Next slide. And what we found was only about 20% of the patients that we thought might have undiagnosed hypertension actually did have hypertension. The other 80% didn't. It was a spurious blood pressure reading, maybe. So it turns out, a good chunk of the potentially undiagnosed hypertension patients did not actually have hypertension. And there are some studies that say if you take this group and look a year later or 2 years later, they do end up with hypertension. So they still do bear watching. Next slide. Keep going. So this is our run chart of our undiagnosed hypertension percentage over time. So you can see we're running right at about 2.5% at the end of last year. And then I have another, next slide is just from last week. So we're running about 2.6%. We have total, if you look at our last 9 months, we have about 300 undiagnosed hypertension out of 12,000 hypertension patients. And we can break it down by provider, we can break it down by site, and any which way. Next slide. and this is part of our undiagnosed hypertension report. You can see here's the breakdown by provider. We even look at our podiatrists, our chiropractic visits, when they usually don't do a blood pressure, but the podiatrists do a blood pressure because generally they're dealing with a lot of diabetic patients anyways. So by provider type, we can see when the last blood pressure was done and what the reading was and the number of times they had a high blood pressure in the last 9 months or the last 6 months. Next slide. And again, back to our alerts app. Next slide. So this shows, if you look at the alerts app snippet there, you can see this is an actual patient. And they have potentially undiagnosed hypertension. You can see, so most of the stuff is black, meaning it's up to date, it's in control, it's meeting goal. I don't know why this patient had an A1C at 4.8, but they did for whatever reason. You can see their last blood pressure is 147/101, so that turned red. And also, they must have another high reading in the charts within the last year because the undiagnosed hypertension question turns red. That only comes up if they have 2 high readings in the last 12 months. So this alerts, so when we're seeing this patient, this kind of catches your eye. There's like a lot of red and blue, and then a lot of black and blue, which are normal, and then a few red things tends to get everybody paying attention to that. So I see that out of the corner of my eye. We use this alerts app when we huddle, and we do pre-visit planning for all of our patients. And so this would be an area we would focus on, is like, oh, this patient might have undiagnosed hypertension. Let's make sure we do a good job with the blood pressure check today. Let's ask the patient about it. Do they have a history of hypertension? I might need to add that to the problem list. I'm certainly going to I'm going to put something about this in the note today. It gets the MA's attention too, because they see this in the same way. And I think the key thing here to be able to develop tools like this is to make sure you have access to your data and get your own programmer. And if it's a doctor, it's great. Not everybody has that luxury of having a doctor who was a former programmer, but you at least need to have one of your physicians working hand in hand with your data person or people, and own that data and do something with it. Next slide. When I say own the data, I mean literally get it in your contract with your EMR vendor. So next slide. And we also have, so our population health folks work on this. We have a one-call concept. So if we're running a report on diabetes out of control, or diabetics who need their foot exam, or mammograms, the report just doesn't tell that one query. It tells all of the things that one patient needs. So if we're running a report on this month, we're going to emphasize breast cancer screening, and let's see everybody that needs a mammogram. If they also are due for an A1C, or their last blood pressure is out of control, or they need a retinopathy screening, this report will tell our population health folks that, and they have the authority and the protocols set up to order everything that patient needs. And I think this report was actually a mammogram report, but it's showing people with A1C out of control, and blood pressure out of control. Next slide. So this kind of summary slide of what we did to try to limit our undiagnosed hypertension population. We standardized our blood pressure measurement. We retrained all of our MAs and the physicians too, to how to do blood pressures. We did we inserted into our huddle, which is now, we used to have like a huddle piece of paper, but it's so ingrained we don't use the checklist anymore. It's just kind of in our brains. But to check the last blood pressure, recheck the blood pressure if elevated, like I mentioned. We configured the alerts app to alert for the last blood pressure and turn red if it was high. And we configured that undiagnosed hypertension alert for us. For our population health approach, we set up some RN and care coordinator or medical assistant or health coach visits. We took our toughies, our hard to control, no matter what I do type of patients, and we stick the pharmacists on them. And so we had a whole cohort of a couple of hundred people that were kind of recalcitrant, out of control blood pressure folks, and 4 visits with the PharmD for most of them got their blood pressure under control, and it stayed for a year. We have registry recalls, a list that we're doing. We developed before COVID phone follow-up visits. We have hypertension protocols, which I'll show you a glimpse of on the clinical side. We deployed some ambulatory wireless home blood pressure machines so that we could get some data on some of the patients that we weren't sure about. We've been having integrated behavioral health for a long time at Neighborhood Healthcare, and we'll get those folks involved if we're having compliance adherence issues. And we try to make our data available and transparent to everybody. Next slide. Here's an example of our hypertension treatment protocol, what it looks like. Next slide. So a little blow up of this. Go to the next slide again. So you can see we try to start out with, this doesn't work a lot of times. I would suggest you kind of look at your health plan formularies before you develop your protocol. We developed this, and then it took us about a year or a year and a half battling. San Diego has the honor of being a multi-decade pilot project for the state of having as many health plans for Medi-Cal as they want. So we have like 7 or 8 different health plans. They all have different formularies. And none of them covered the lisinopril HCTZ combo. It took us about a year to get the health plans to get this on their formulary, but most of them do now. But the key thing is it's kind of overcoming clinical inertia. We had a lot of, oh, your blood pressure is high today. Let's not do anything and check it again in 3 months. And so we really tried to hammer the physicians, all of the clinicians, if that, you don't wait 3 months if you have a high blood pressure, you wait 2 weeks or 4 weeks. And if you don't have room in your schedule, have an MA follow-up blood pressure, MA blood pressure check, or an RN blood pressure check, or a health coach blood pressure check in 2 to 4 weeks. Next slide. Go next slide again. And really, so we're really, all of these folks have been promoted now, but these were my health coach and my 2 MAs. Now one of them's running our office, one of them is a back office supervisor, and the other head of our population health department. But anyways, it really depends on your team more than anybody else, more than me as a physician, because I'm trying to figure out, is this CHF or is patient fluid overloaded or underloaded? They've got CKD4 and CHF. Do I dry them out? Do I give them more fluids? I don't know. So some of the more mundane stuff, it's not really mundane, but it's really important, but other people can do it. Next slide. Here's some references to the hiding in plain sight. I think my slides are open to be made available to anybody. So here's some of the links. Million Hearts put out a great change package on hypertension control that's really awesome. And it's, unlike some things we get from our government, it's not a huge tome, and it's very practical. Next slide. All right, so we can skip this one. This is basically a reiteration of what we did versus what the CDC is recommending. There are still some hurdles. So we have, it's hard to get some patients into the office. We did have some disagreement between HEDIS and U.S. Preventive Services Task Force on the ambulatory blood pressure monitoring. And for community health centers, we have a bunch of this stuff that we're doing right now is completely unreimbursable. So hopefully some of that will change. Next slide. So the HEDIS up until right now has excluded all of the non-office-based blood pressures. And specifically reported by or taken by the member. However, with the COVID, NCQA is now allowing blood pressure taken by the member. They were allowing some blood pressures taken by a digital machine that had some sort of a readout or transmission of data, and now they're allowing basically the patient to write it down and report it to you in a virtual visit, so a telephone or video visit with the patient. So due to COVID, we've actually been able to capture some more blood pressure data that may even be more representative of what's really going on in the patient's life versus what's happening in our office when they come in. Next slide. And we can skip this one. Let's go to the next slide. I want to kind of get into some of the COVID response. Next slide. So again, this is a summary of what you can do to make sure you don't have a lot of undiagnosed hypertension in your practice. Next slide. All right, here's the answer to the quiz you've all been waiting for. So the answer to how many people have undiagnosed hypertension, somewhere around 12 million. Next slide. And how do you know if you have hypertension patients hiding in plain sight? You can use both A and B. Use your registry and compare it to what CDC hypertension prevalence estimator estimates for your practice. Next slide. And this is according to the hiding in plain sight study. Their comment about why we're not, why these patients are going untreated, it's basically because a lot of us have inefficient clinical systems. Next slide. What's the best way to rapidly improve? And the answer to this one is changed because it's now A, B, and C. You can enter the home blood pressure readings into the blood pressure field in your EMR. Next slide. And how can you reduce mortality and morbidity is by doing all of the above. Prayer never hurts either. Next slide. So this is what was happening to me when coronavirus hit China and then Thailand. I was in Thailand when the first cases started showing up in Thailand, in the middle of a bike trip from Bangkok to Surin, where I was doing some volunteer work at a clinic there. Next slide. And this is kind of a graphic of how the virus spread in Southeast Asia. Next slide. And then to Washington from there. And if you look at the date on this, February 7th, this was a Thai news headline that that hit while I was there. Next slide. So we had an emergency meeting on Saturday, March 7th at Neighborhood Healthcare, and these were some of the images that we were seeing out of Italy, New York City later, Washington State, and our assumptions were we're going to have a huge surge in patients. They're all going to be sick with coronavirus. Our staff's all going to get sick and die. We don't have testing. We didn't know if it was aerosol or contact spread. WHO and CDC were saying, oh, it's just contact, don't worry. But a lot of doctors were getting sick, even taking precautions, so that didn't seem right. We looked at our patient base, and almost everybody's falling in the high risk category because we're a community health center, so just low socioeconomic status. We didn't even know how much of a factor that was at the time, but we kind of figured. And we were looking at all of our pediatric patients as little petri dishes, and we were scared. Next slide. So we had an incident command system, and we had some training in that on bioterror years and years ago. So we actually had an incident command system set up, even our own little community health center. Next slide. So the key thing that happened for us is under the emergency declaration, the HIPAA rules were lightened, and community clinics are being reimbursed for both telephone and video visits. And a lot of our patients, there's still a huge digital divide, and a lot of our patients don't have the technology to do video telemedicine. So we've been on the phone a lot. Next slide. We can skip this one, go to the next slide. So we went through, well, probably everybody else has gone through as far as setting up outdoor clinics, isolating our respiratory patients, getting all hands on deck, planning for drive-up visits. And it turns out like our visits started to plunge instead of going the opposite way. Next slide. We went through the whole PPE analysis and set up some tracking for that. And we're worried about running short, but we never have run short, and we've got plenty still. Next slide. Mainly because we didn't see that surge of patients. The patients stayed home. Next slide. Our visits have been able, we were doing about 1,400 or 1,500 visits a day, counting everything before COVID, and now we're 1,300, 1,400, depending on the week, visits per day. We're just doing medical and BH only, and our breakdown is about, we started out 15% live. The last couple of weeks we actually are about 40% live visits. We're still only about 5% video visits, 80% phone. Now we're kind of down to 60% or 55% phone visits. Next slide. Our BH visits have actually increased because they don't no-show when you can call them on the phone. This is a breakdown of our visit types again, and that's going up on the live visits the last couple of weeks. Next slide. This is a graph we're using to track a video versus, virtual versus live visits. Live is virtual. Live is, sorry, live visits are the blue on the bottom graph, and virtual are the red on the bottom graph. Next slide. So we had to set up some custom reporting to track that. And this is kind of like what my type of patients that switched pretty much overnight from a bunch of live visits, typical primary care stuff, to now phone and video visits, typical primary care stuff. Next slide. We did preserve some of our live visits, like high-grade colpos, family planning, well baby and child up to 2 years old with immunizations. And at this point, we're basically trying to keep our high COVID risk patients out of the office, but if they want to be seen live, we'll see them. Or if we feel like they need to be seen live, we'll see them. Next slide. And this is all the different things we tried to do video visits, and we're still struggling with that because of issues on the patient side of things. Next slide. We cohorted our care teams. We split our offices in the clean and dirty sides. And this x-ray is one of our first COVID patients that we diagnosed here, who spent 5 weeks on the ventilator and survived, fortunately. Next slide. We can skip this one. Next slide. This is just a physical setup. We did get some grants, and one of the things that we've done with the grants, go to the next slide, to sort of mitigate some of the issues of not being able to see the patients alive, is we set up a clean lab, separate clean lab site to make sure our patients who really need lab don't have to mix with potentially ill patients. So it's a whole different site that they can go to and get blood drawn. And we trained our lab staff, our phlebotomy staff, to do vital signs so that we can grab some of the blood pressures before they get their blood drawn. And we also are adding a mobile phlebotomy unit that will also be doing vital signs. We actually bought 3 RAV4s, and we're sending them out to people who need labs, they need their A1Cs, their glucoses, their lipids, and can't come in or don't want to come in because they're scared or are super high risk. And so we're just taking the lab and the vital signs to them with an iPad so we can do a video visit. Next slide. We've had 18 different Kaizens. We have some lean lean green belts and black belts around, and they've set up a bunch of Kaizens to kind of redefine our workflows. A lot of our workflows during COVID have changed. Next slide. And again, so it really is a reflective of our staff and our resilience and flexibility of our staff to change how we've been able to flex how we provide care in this time. The one thing I would tell you I'm very concerned about is we're hearing from the governor's office and from the Medi-Cal office that reimbursement for telephone and video visits for Medi-Cal patients is not going to continue past the end of the current emergency declaration, which I think ends in October 25th, has us very concerned because our offices, and we're like most clinics, we've crammed we literally have people working out of what used to be a bathroom in our offices before COVID. So there's no way we're going to be able to maintain any sort of social distancing or hygiene in our offices and without continuing a good percentage of our visits via telephone or video. So that's a big concern to us if we're going to be able to continue that or not. At the federal level, they're saying yes, they're going to reimburse for this, and at the state level, they're saying no way, Jose, at this point. So we're all very concerned about this. I think I'll end it there just because I see what the time is and open this up for questions.
What a fantastic presentation, Jim. Wow. I was really interested in what you said about when you have really difficult patients, you get them connected with a PharmD. Could you elaborate a little bit on that?
Sure. So we have one retail pharmacy. So one of our 3 pharmacists is just basically runs our retail pharmacy. That's our internal for our patients only clinic pharmacy. And we have 2 clinical pharmacists who take turns doing MTM clinics. One of the clinics they run is for our recalcitrant out of control hypertension patients. And so they will bring the patient in for a series. Generally, we've got the protocol calls for 4 visits. We've had some patients that need 6, 8, or 10. But of the patients that we haven't been able to control with our usual, what I like to think is good efforts and good care, we get the pharmacist. We get the pharmacist to work with them, spend more time with them, bring all the meds in, do med rec. Try to figure out what's going on, what they're taking, what they're not. We do refer to our behavioral health folks when needed, if that seems to be part of the issue. And they just really work one-on-one with the patient well, it was face-to-face, now it's all by phone. But prior to COVID, face-to-face for 4 visits and then with phone calls in between. And they just really do intensive focus on the hypertension, and that includes lifestyle as well, and behavioral health, and if there's social determinants involved, we try to do what we can to address those.
We do have quite a few questions in the chat box. And I know Dr. Stock was seeing patients today. She is trying to join us for some Q&A facilitation. But Dr. Yu, would you mind taking over the Q&A
let me do that.
Thank you. Thank you.
So Dr. Schultz, there are a few questions about your social determinants of health. So could you answer a couple questions? One is, could you articulate the value and the return on investment of that? And secondary to blood pressure control, how do you address adherence with a social determinant of health lens in your work based on the data you collected? Thank you.
Well, the social determinants, neighborhood healthcare has no ROI on that. That's all costs to us at this point. I think society is probably a good ROI. For our health plans, there's probably a good ROI. We haven't been able to pry any money out of the health plans to support this effort. We're just doing it because it's probably the right thing to do. What we've done, because we have there are a couple of things, we were worried about doing screening for something we don't have an intervention for, right? So what we've done is we're fortunate in San Diego County. We have an outfit called 211 San Diego. That's kind of a central place where basically a one-stop shop for us to call if the patient needs food, if the patient needs housing, if the patient, all of those social determinants are gathered together in 211 San Diego. So kind of the easy answer, the easy solution to everything for us is call 211. What we've done with the social determinants folks is we kind of risk stratify them based on how bad their score is. And we've identified one of our behavioral health folks to be the social determinants, what do we call him? Something like social determinants champion or something like, I can't remember what his actual title is, but he's like the expert on taking the people who fall into the highest risk social determinants category, and he'll do one-on-one intensive intervention with them. Basically, he meets with them for at least an hour, figures out what all the issues are, helps them rather than just give them a phone number to call, helps, calls for them and kind of walks them through hooking them up to the agency that can help them, because generally we don't have the resources in-house to respond to a lot of that stuff.
Got it. Thank you.
And as far as how it impacts hypertension, I don't know. I don't know yet.
Well,
we haven't looked at that.
Congratulations to you for focusing that effort, because I think the measurement industry lags behind and all that, and your willingness to invest in that is great. So on that note, we have a question about, we're very impressed with your work, and there was a question about what are your strategies to have your patient populations choose you to be your medical home as opposed to some other organization?
Well, that's an interesting way of putting it. It presumes that they have a choice, which they actually do. So it's interesting. I have this discussion with our executive team all the time. We're in an area where, first of all, to set the scene, San Diego does not have a county healthcare system. I know some of you are in counties that have a county hospital and county clinics. San Diego has none of that. So the FQHCs are basically the safety net for the outpatient side. So the patients if they have Medi-Cal, they can go to, I'll just call it what I call it here, a Medi-Cal mill. I hope nobody slams me for this, but there are certain private offices generally that are staffed by a nurse practitioner or a PA, nominally overseen by a physician somewhere. And they churn through, because Medi-Cal pays so poorly on the private side, they churn through 60 visits a day, because it's the only way they can keep the doors open. So the patients can go there, and they do go there because they'll get seen quickly. Quality would be up for debate. And then you might look at, like, we have clinics, other clinic organizations in our own community. So like in El Cajon, where we have one of our clinics, there's 4 community health center organizations. The way I look at it is, if they go to any one of them, they're going to get pretty good care. I don't really care. But from a business point of view, they might be viewed as a competition. So, we try to provide good quality of care. We use NRC to track patient satisfaction. We respond to all the negative comments. So we're trying to do all of the sort of customer service stuff. We try to provide good access. We're actually in the middle of moving to open access right now, so that there's not a wait time for appointments. So we're trying to act like we're in a competitive dog-eat-dog market and treat our patients that way in a good way.
Got it. Thank you.
I have a question for you. First of all, as as a CMO at an FQHC, I can directly relate to your whole presentation. And I would say
Well,
for
thanks.
those who don't truly understand what he's doing, it's Herculean work, everything. We actually have ECW. We understand the challenges with ECW. We actually now have an overlay called Zara that's supposed to help us get reports. I believe you might have presented at CCLC before, because I remember these applications, and maybe it wasn't you, but I think I've heard you. But that being said, that's phenomenal work you're doing. A question I have is, when you're doing your dashboards with providers, are your patients truly impaneled such that your providers can own that information versus, oh, that's so-and-so's patient, I just saw them last time?
Oh, yeah. So that's, I hate it when people ask me this question. So yes,
Sorry.
they are.
We have the same problem, that's why I'm asking.
Yeah. Yes. So basically, yeah, we've had to deal with that. Our patients are in panel, but they might not be in the right panel, and we don't employ anybody on panel maintenance at this point. So who knows where our panels are. I see my panel, and so I know some of those patients on there aren't mine. So what we try to do is take the philosophy of their neighborhood healthcare patients. It doesn't matter if they're your patients or your partner's patients, they're our patients. And so at this point, we don't reimburse our physicians based on their quality scores, because we haven't figured, that's part of the problem, is the paneling the patients is an issue. And how do you treat a pediatrician versus a family practice versus internal medicine versus psychiatrist, and have an equitable quality based. I'm all ears if anybody has any great ideas, without, you know, having a staff of 6 to figure out the quality incentive program. So we don't reward, so nobody gets penalized other than embarrassment on the rankings that are very open to anybody to see.
Thank you.
So how are we doing on time, Hattie?
Well, we might run over a few minutes if people are, Jim, are you open to answering a few more questions?
Of course.
Wonderful. And welcome, Dr. Stock. She's been seeing patients all day. Could you unmute yourself and mention?
Yes. Yeah, thank you, Hattie. So thank you, everyone. And as we come to a closure of our meeting, I want to thank Dr. Jim Schultz and also Dr. Catrina Taylor for fabulous presentations. I missed a little bit of Dr. Taylor's presentation, but I am absolutely delighted and having very big ideas right now on how we can use this. And it's given me hope. You know, thank you for that. I think that one of the biggest challenges, I think, for all of us are to overcome these inefficiencies. And I feel very inefficient. Just last week, I had Apex training again, because I said, you know, there must be a way that I can get better at this. And as I look at your presentation, I see how much better ways of doing this are. I think I absolutely want to own the data. I thank you for those ideas. Being part of a, you know, academic center, we're trying to get into different systems and ways of doing things. But I think these programming these apps where you own your dashboards and have the data readily available is priceless. It's priceless.
It's made a big difference for us, for sure.
Thank you. Yeah, I am going to try to get this for my own personal practice, but as the RightCare initiative, we're trying to get communities to have these ideas. We can't thank you enough for this. And I have a question for you. How do you're using your models of where behavioral health seems to be a key element, right? And I think we miss a lot of that when we're on our metrics-based systems, metrics on performance. And to move our performance, it seems like behavior needs to be intertwined, if not in every single problem, it needs to be a factor. How do you factor that into your practice? And you mentioned a little bit of this risk score. Would you have a recommendation of how we can do this at a higher level, or not a higher level, but on a bigger scale in our practices from your vision?
Yeah, it's tough. The other hurdle we face in California, and Dr. Brooks knows this too, is if I'm seeing my patient as a physician for medical issues, and I identify a behavioral health issue, I might have a counselor sitting in the office right next door to where I'm seeing that patient. If I walk the patient down there and do the warm handoff, that one of those 2 visits doesn't get paid for today. Because there's a rule in California, not in other states, but in California, will not reimburse medical and behavioral on the same day. They'll do medical and dental on the same day, they'll do behavioral and dental on the same day, but they won't do medical and behavioral on the same day. So that's another sort of structural barrier to providing the best care. So basically we do it anyways, and we eat the warm handoff visit. But we do try to get the patient back for follow-up with behavioral health. We use our behavioral health folks for, lifestyle modification stuff. So people that are struggling with smoking cessation and the 1-800-NO-BUTS didn't work for them. People are with medication adherence, people whose depression or anxiety is just like the overwhelming thing at the moment or chronically in their life. And so it's really preventing them from caring about or paying attention to their medical issues. So that's kind of how we use it. We're pretty liberal with our use of behavioral health, and figure, that one visit that we're not going to get reimbursed for is just kind of a lost leader to other things that provides better care in the long run.
I have a question. If people have run out of their questions, I want to acknowledge that Wayne Chen had a question about whether you see an impact with prayer or meditation, and do you do any training on that in your hypertension program?
We have not. Well, so what we'll do is if we identify patients that are having those type of issues, we'll either refer them to ask them to go to their spiritual leader, or we'll send them to our behavioral health folks and have the behavioral health folks go to work on them. And they're very good about teaching relaxation techniques and things like that. We don't have, I see the question, we don't have any outcomes data on our social determinants of health screening yet. That's something in the future, because we've really focused on getting the screening done in most people. And now we're trying to implement ACEs screening, once on our adult patients and annually on the kids.
I see Alyssa Meyer would like to answer live. Is there a way to give her control of the microphone?
And we also have Bob Kaplan, who headed behavioral health for NIH, wanting to weigh in on that one, I think.
Actually, I had a slightly different question. So, I was curious about your comment that USPSTF and HEDIS really have different views of ambulatory blood pressure monitoring. And, I was actually at ARC when the task force was working on that. They just looked at tons and tons of evidence. And what comes out of that is that measuring blood pressure in the doctor's office is really not a very good way to do it. And that, there are there's all kinds of evidence, which I'm sure you know about, but just curious about how you start to address that. They have the problem of masked hypertension, people. So there's white coat hypertension, but then there's the reverse of it, people for whom being in the doctor's office is probably the most peaceful place they ever are. And so, how do you address that going forward?
Well, I think we kind of leave it up to the individual provider of how they want to handle that. As an organization, we're mandated to report by HEDIS definition to all of our payers. So between the 2 counties, we have about 10 HEDIS reports that we have to generate. So that's kind of what we run our metrics on, because we do get some years we get some pay for performance dollars. I don't know what's going to happen this year. So there's like actual funding to help fund our population health and some of these unfunded visits that we're doing. That's kind of where we get kind of a theoretical return of investment. If we do some unfunded health coach visits or pharmacist visits and we do better on our pay for performance, then maybe that helps fund that and some of our population health efforts. Clinically though, I think we all have patients that are really good about taking their blood pressure at home with a good machine that we verified in the office is accurate against our machine. And, they're 125/74, average at home, and they don't have any high readings, and they come in here and they're, 148/92 all the time. So that's the white coat hypertension. We haven't picked up the opposite, the masked hypertension as much, but I don't know that we've really looked for it that well, either.
And HEDIS does not allow you to report the values that for people who monitor their blood pressure at home.
Oh, it's the last blood pressure reading in the office done during a billable visit, basically, is how the health plans have made us report it.
And not the average of multiples in the office. Huh.
So you could have, your average could be 130/78, and you can have the last reading be 141/91, and that's the one you have to report.
So maybe that's something we should talk to HEDIS about.
That would be wonderful. Right now they are allowing, NCQA is allowing use of the home blood pressure readings because of COVID. Now what happens after COVID, I'm not sure.
I have a question for our resident cardiologist, Dr. Stock, who's on the line. We actually have another cardiologist with us, Dr. Sky, as well. But as someone whose mother died of uncontrolled hypertension, I monitor my blood pressure very carefully. And we come from a long line of not so tall people. And so one of the things that they say is that you're supposed to have your feet planted on the floor. Now for tall people, they can't even imagine that I almost never have my feet flat on the floor because the chairs are all too high. So from a cardiologist perspective, is that actually raising your blood pressure?
So Hattie, that is a great question. It makes sense to me, but I think that's where machine learning comes into our, as we look at risk factors that we imagine and think about and seem logical and plausible, and we have hypotheses for all of these things that we imagine, I think that we need better ways of risk stratifying patients so that we can properly triage. Like, I was very impressed when Dr. Schultz mentioned that 80% of the patients who had a high blood pressure reading, for example, on one instance then come down, but then subsequently you see their blood pressures comes up. Maybe integrating different measures by algorithms that are beyond our, capacity as practitioners, such using machine learning and being able to triage and risk stratify so that we can make better uses of our, very limited and very inefficient clinical practices. At least in my site, I think that things like that are going to jump out. Dr. Schultz, do you have any information on use of machine learning or any of these other?
We have not. We've looked at some machine learning algorithms just for risk assessment and risk prediction for our patients, but it's just, at this point, it's just experimentation. I haven't really done anything with it.
Yes, so
and we're trying to use some machine learning stuff to figure out, you know, we have 70-something thousand patients. Which ones do we really need to get in first? You know, how to prioritize that 70,000 list of patients, and predicting what might happen in the coming year. But again, it's not ready for prime time for sure.
Yes. So Hattie, for now, maybe high heels?
A stool, bring a stool with you, a footstool.
Footstool that you can deploy and put your feet up.
I just think it's funny because if I stop in the middle of my busy workday and I, you know, take my home blood pressure, it's maybe a little high, but then if I follow all the directions, you know, sit quietly, have your feet on the floor, all the things you're supposed to do, it's very, very excellent. But I think how strange it is that nobody's ever doing those things in real life. I mean, maybe some people are, but I don't know them, people who are quietly sitting. And so which is the real number? Is it the one when you're actively going about your life? Or is it the one that gets you a lower number through sort of artifice?
Yeah, I think probably the higher number is the one that we are always more convinced about. Yeah, I think for now, I don't have a good answer for you. Joseph, you want to chip in? Joe Sky?
If you can unmute, yeah.
Yeah, two comments. So part of it is from flying experiences, fighter pilots can raise their interthoracic pressure by up to 60 millimeters with a good muscle strain. And so part of the idea is that you want to be sitting without using any muscle support. But you're only talking about a couple of millimeters of pressure with something like the legs. And then the second thing is I'm always suspicious of average blood pressures when I learned that probably dates back to early flying days when the pilots and astronauts would quibble on their blood pressure readings because it was disqualifying for duties. And as best I can tell, that actually traces back to the early Army Air Corps and Air Force. And some of the most recent data is we really shouldn't use averages.
You know, it's interesting, Joe, that epidemiologists have debated about this for decades.
Yeah.
You know, there's tons of really boring studies in literature where they do left arm versus right arm and, you know, sitting versus prone and whatever. But one of the things we do know is that most of the big epidemiologic studies do a pretty poor job of measuring blood pressure. You know, they've gotten better in recent decades. Nevertheless, even with all that measurement error, blood pressure turns out to be a really good predictor of cardiovascular events. So, so that leads you to believe that it is important, and even with error, it's meaningful.
I completely agree. Those are excellent points.
Dr. Baumer's also on the line with us, and he's talked about the importance of ambulatory 24-hour monitoring. Can anybody weigh in on that? And Bill, can you unmute yourself?
Sure. Can you hear me?
Yes.
Well, first of all, two important things, Jim, I really appreciated. One was your alert app, because I think that is an extremely valuable tool for any clinician. And I want to commend you for finding a physician, hiring them who was a previous programmer. So the ability to be computer programmer and a physician is excellent. And I think you should be commended for that. And by the way, can you give me his name and phone number? Number one. Number two, I liked your comment of resistant hypertension, which we all deal with. But I especially appreciated your dog-eat-dog analogy of sick the pharmacist on the resistant hypertension, because that is an effective way. You've got a identified patient through your data set, and you have a motivated individual who has educated the pharmacist to actually attack the problem of those outliers. And I think that's a very efficient and effective way. And I want to commend you for an overall totally comprehensive approach to cardiovascular care and overall healthcare at your system, which has taken, I know, a lot of work and effort, but I think you're making a very good impact on that. Now, related to Hattie's blood pressure question, we do have a lot of data that would suggest that ambulatory blood pressure is superior to a single office visit or multiple office visits, and even superior to home blood pressure monitoring. And that gives us more robust data. The question for Hattie of measuring her blood pressure, the regular Omron and the oscillometric cuff, as long as it's at the level of your arm on a desk, et cetera, should be accurate. But if you're uncomfortable with your feet dangling, then that's going to alter your blood pressure. So the important thing, as Joe said, is it has to be a totally relaxed setting. 5 minutes of rest, relaxed, not being stimulated by your computer, your iPhone, or anything else, in a relaxed area, and we get that measurement. We obviously know your blood pressure goes up at other times during the day, and hopefully it goes down during the evening hours when you're sleeping at that point. And it's really the average of all of those on ambulatory that makes the most sense. And even though we might be worried about your blood pressure going up during a meeting or something like that, it may be just as important what your blood pressure does during sleep, because that's the period of time where you carry the greatest burden to your cardiovascular system. And if your blood pressure is lower during the nocturnal hours, that may be very protective for your cardiovascular system. So we will get more data on it, but ambulatory is certainly the way to go with that. The unfortunate thing is we don't have a lot of ambulatory cuffs to give out to patients and monitor. We're seeing CMS release reimbursement for that. So I think that's a good sign. And the more that we can use it, the better. And that's the only way that we're going to detect mask hypertension in that patient population. Because as you said from the earlier talk of the hidden number of individuals with hypertension, and you alerted to Janet Wright's article, we don't really know the unknown in that population unless we really have ambulatory blood pressure, which is, I think, an important tool that we can all use at this time.
I know that it's late for a lot of our wonderful presenters and very active participants and leadership. Just love this group and love the support system that this Zoom platform has created. I'm so impressed with all the work that you're doing, and just want to thank our public health heroes out there. I'm wearing this scarf today thinking of Deborah Birx and what our coronavirus heroes are doing, you know, every day out there on the front lines. And among those are many on the phone here. So often we have you joining with your masks on, and I just want to commend you for your efforts and say, please don't let your guard down with the smoke and rushing and kids needing help. You know, just please take care of yourselves. We need you. And welcome to our leadership team, Dr. Brooks.
Thank you.
Welcome.
Happy to be here.
Thank you. Signing off.
Thank you. Thank you, everybody, again.
Thanks
Thank
again,
you.
Jim. And
All right.
you're such a gifted teacher. Really appreciate it.
Thank you.
You
Bye-bye.
came
Thanks
right
for having
through.
me.
Peace and be well, everyone.
Your presentation cleared up the smoke in Northern California.
Ah, that was my goal. So thank you. Bye-bye.
Thanks, Jim.
Bye.
Take care.
Thanks, Hattie.
Bill, what a hero. You stayed with us that whole time and you were on when nobody else could get on. How did you do it?